Good evening. Dr. Paul Anett's my name, and I welcome you today from the sunny Magenta Shores Resort in camp with the New South Wales Origin Team 2020 for the upcoming State of Origin series. The topic I'd like to present today is on musculoskeletal mimics. This is a topic that I've been considering presenting for a number of years, as I feel a lot of the conditions that will be discussed throughout this talk are important conditions that you may encounter commonly within your physiotherapy practice. The first case that I'd like to present is Mr. AS, a 25-year-old male who presents to your clinic with a 3-month history of left knee pain, swelling and stiffness. Of note, this has come on fairly without any significant trauma and fairly insidiously. So he presents to you as the physiotherapist and has his standard treatment, including treating the knee effusion, doing work around the soft tissue structures of the knee, and commencing a rehab program for his quadriceps and gluteal muscles. It may have also been suggested that he take an over-the-counter anti-inflammatory medication. The question I always pose in a patient like this, and any other patient you see in your clinic, is why has this happened? He's a young man, 25, unlikely to have osteoarthritis in the knee. There's been no significant history of traumatic event, yet he's presented with a knee effusion for no obvious reason. The importance of this is that I would consider in all presentations of musculoskeletal symptoms, a medical condition should be considered. Just because a patient plays sport and develops a musculoskeletal symptom does not always mean that it's due to injury. And just because an 11-year-old boy plays soccer and develops knee pain doesn't mean that he's had an injury. He may simply have a more sinister problem going on there, such as a bone tumour. As I'm sure you're all aware nowadays, often the primary presentation of any musculoskeletal complaint is to a physiotherapist, or in my experience, they've usually tried the chiropractor, osteopath, naturopath, massage therapist, and even Reiki practitioner before they actually make it to see a medical practitioner. As Mr. AS is more likely to see a physio for his initial assessment and diagnosis than his GP, we must always consider the potential for an underlying medical condition. What are the main conditions that we should consider, and I would like to consider in this presentation today? The main conditions to consider are inflammatory arthropathy, either in the form of rheumatoid arthritis or a seronegative arthropathy, including ankylosing spondylitis, psoriatic arthropathy, or enteric arthropathy. Other presentations could include crystal arthropathy, such as gout, potentially cancer, either primary or secondary, and also associated neurological conditions. What are some of the common symptoms of inflammatory joint disease that would make me concerned that this could be an underlying problem? One of the main ones is actually an absence of precipitating event or injury. In the past, I've had a number of patients referred to me for an ankle sprain with pain and swelling with no history of trauma. Inflammatory symptoms may include swelling, morning or start-up pain, and pain that improves with activity and worsens with rest. Also, a response to medication, such as anti-inflammatories, may be consistent with an inflammatory condition. A positive family history should always be asked for, and also associated symptoms, such as skin rash or psoriasis. I'd like to present some more cases now to try and illustrate different presentations of medical causes of musculoskeletal symptoms. The first is Mr. GG, a 57-year-old and very pleasant man who presents with a 2-month history of right forefoot swelling, but particularly around his third toe. He attributes this to doing increased training with skipping, wearing poor footwear, but unfortunately his symptoms have not settled with boot immobilisation or intermittent anti-inflammatories. Otherwise, he's medically very well. This is a photo of his foot, and the main abnormality we can see is the noticeable and generalised swelling of his third toe in comparison to his other toes. This condition has a specific name known as dactylitis, or colloquially known as a sausage toe, as it clearly looks like a sausage. If you ever see this in a patient, it is always abnormal and almost invariably related to an underlying inflammatory arthropathy. An X-ray is important to obtain to exclude a fracture, although in this case there was no history of trauma. Mr. GG improved with regular Mobic 15 milligrams daily, although continued to have ongoing symptoms. A basic inflammatory blood screen was normal, and he subsequently did very well with the cortisone injection given into his third MTP joint and second and third intermetatarsal bursa. He was referred for a rheumatology review, but his symptoms settled and no further medication or treatment was required. So what constitutes an inflammatory blood screen? This should include as a basic set of tests a full blood count and generally blood salts and liver function tests. It's important that the tests include both of it, an ESR and a CRP, to assess for inflammation in the body, full stop. Whilst these are non-specific tests, when they are raised, it is much more significant in terms of a medical presentation. The patient should also have uric acid tests performed to look for underlying gout, and also iron studies, as iron overload or hemochromatosis can be associated with degenerative joint conditions. It's important to perform a rheumatoid factor and also to look for the potential for genetic causes of his symptoms, and in seronegative arthropathy, HLA-B27 may be positive. In addition, consideration must be made for performing an ANA and other more specialised inflammatory blood tests. The next case is Mr. MD, a 45-year-old fellow who is well known to me as both a builder and a golf player. He was actually seeing me for a coexistent meniscal tear with a strong history of trauma, although at the same time he mentioned a very non-specific and 3-month history of bilateral shoulder girdle pain with quite a significant period of morning stiffness, at least until mid-morning, and a feeling of generalised fatigue. There was no precipitant to this, and he's been able to continue on with his normal activities, including building and golf. Of note, his clinical examination of the shoulder was quite normal, including a normal range of movement, rotator cuff strength, and negative impingement tests. Whilst his symptoms were quite non-specific, they did sound very inflammatory, particularly the long and protracted period of morning stiffness. He was investigated with a set of inflammatory blood tests and had quite a markedly raised CRP and a mildly raised ESR. A potential diagnosis of polymyalgia rheumatica was made, and he was treated with prednisone 20 milligrams daily with almost immediate relief of his symptoms. Polymyalgia rheumatica is an inflammatory condition of cause unknown, typically occurring in patients over 50 and more commonly in females and males and Caucasian. It generally presents with proximal limb girdle pain, both in the shoulders and the hips, and most notably a significant period of morning stiffness that improves with activity. It is extremely sensitive to prednisone, and not uncommonly a test dose of prednisone may be used to try and make a diagnosis of PMR. It's important that patients who you're considering to have PMR should be referred for inflammatory blood tests, including an ESR and a CRP. The next case is a 23-year-old female who presented with a 3-year history of non-specific left lower back and buttock pain. She noticed the pain was worse with prolonged sitting and standing, and there was some morning stiffness for around 30 to 60 minutes. She felt her pain did improve with activity. Clinically, there was pain more on extension and quadrant testing, and she had a strongly positive Faber's test, so putting the hip in a position of flexion, abduction, and external rotation. In addition, she did have a positive posterior pelvic provocation test. This is her MRI scan, and on these particular T2 signal weighted signals, we can see quite marked inflammation and secondary bony edema around her left sacroiliac joint. She was initially commenced on Mobic 15 milligrams daily, which she did find helpful, and a set of blood tests demonstrated again a raised CRP at 18.2, and she was positive for a HLA-B27. She was referred for a rheumatology review, and in this case was commenced on second-line agents, initially with solazepirine. Other agents that may be used include methotrexate and also, more recently, some of the newer biological therapies. Spondyloarthropathy is a type of inflammatory joint disease which affects predominantly the axial skeleton, but it can include peripheral joints as well. It is important to consider this, particularly in young men who have insidious onset of lower back pain, but it can also occur, as seen here, in females. Generally, there should be morning stiffness that lasts for more than an hour, and true sacroiliitis presents with buttock more than lower back pain. From a clinical point of view, the Faber's test in true sacroiliitis should be extremely positive. Associations may include psoriasis around the knees and elbows, or potentially inflammatory bowel disease. It's important to mention these in your history when assessing a patient with lower back pain for the first time. The next patient is Mr. M.A., a 40-year-old male. He presented with a 6-month history of mid to upper lumbar pain without any precipitant. He had had half a dozen sessions of chiropractic and unusually had not had an X-ray performed, as this does usually make up a standard part of their assessment. Of note in his history, he did have a past history of melanoma 6 years before. The question with a patient like this is, should we be worried? I'm sure you're all well versed in the findings of red flags, which could include constant pain, night pain, weight loss, fever, and being generally unwell. Any patient who has had a past history of cancer should be considered to have a secondary cancer unless proven otherwise. The two main conditions are melanoma and breast cancer, although colon, lung and kidney will also refer to bone. Consideration should also be made of primary blood cancer, such as leukemia and myeloma. Unfortunately, an MRI scan in this patient did demonstrate secondary melanoma throughout the spine. As might be imagined, this was quite a tough consultation in a 40-year-old fellow with a young family. I'm pleased to say that he has done very well with one of the new biological medications used for treating myeloma known as Keytruda, and he's currently now cancer-free. The last case is a 47-year-old fellow who was referred to me with a 6-month history of right lateral elbow and forearm weakness. He was a builder and extremely manually active, but interestingly enough had never really described pain. He had had 8 to 10 sessions of physiotherapy with some mild improvement, and he was referred by his general practitioner for consideration of either cortisone or PRP injection. This fellow's clinical examination demonstrated a negative third finger extension and grip tests, and only minimal tenderness around his lateral elbow and forearm. What was most startling was that he had a global weakness of his right greater than his left arm muscle groups, which was between both C5 and T1. This included reduced biceps jerk, triceps jerk, or lower normal sensation. It seemed clear at the time that there was a more sinister neurological issue going on. The question was which one? And again, this was another tough consultation in a young man with his wife with what appeared to be a serious neurological consideration. My initial thoughts were he may have either had motor neuron disease or possibly MS, and it was later borne out that he had developed early stage motor neuron disease. So what is my take-home message from this presentation today? Firstly, in all musculoskeletal presentations, medical conditions should be considered. An absence of a precipitating factor is an important negative. Just because someone presents with pain, don't always attribute it to being part of an injury. Consider inflammatory conditions and also nasty things, including cancer, based on history and examination. And always suggest medical review to your patient if the story is not adding up. Even though sometimes it feels like we're at the end of the line for review, a well-trained GP or sports medicine physician will always be able to add to the diagnosis of medical conditions in your musculoskeletal patient. Thanks.